Thank you very much for having me here today. And as many of you might know me, I work at Great Ormond Street Hospital, been there for nearly 7 years. Did some specialty also with some of the orthopedics intervention that the Duchenne might need, or with spinal surgeries, but my main area is working with Duchenne and all the neuromuscular conditions really. So today I'll be talking about physiotherapy and in the ambulant Duchenne, and of course if many of you that might have older child that is not walking anymore, just want to make you aware there'll be focus on the ones that can walk, and then after my talk then Marian will follow up with the non-ambulant Duchenne as well. So just trying to organize what I'm going to be talking about and really the role of what we do in physiotherapy for those boys and the sort of assessment that we do, because we do quite a lot of assessment with them when they come to us, and overall management, and I'll talk a little bit about contractures, which are the tightness of the joints, and the good and sort of bad exercise, which are topics that they always ask us, and I think I want to try to get the message through. So physiotherapy in general in the Duchenne muscular dystrophy, basically our role is to maximize the useful function, and it does differentiate which age and stage. So depends what the kids are up to or the age, and they will change, and that's why it's very important those kids are assessed every 6 months or so we can tailor the exercise and program for what they need at that time and time. So, and then we want to reduce the burden of care, because we know that once you have a child that's been diagnosed with any sort of neuromuscular condition, you ended up meeting a lot of people. There's physio, there's OT, and doctors and consultants and research, so there's a lot of people. So with our assessment, we want to tailor what is needed at certain points, so then to reduce the burden of care that the parents might have. And of course, we want to add quality to quantity. So assessments, we do it to establish a baseline of the physical ability and the function, to establish priorities of the management, to monitor change over the time, and of course to evaluate what we've been doing, the intervention we've been doing, and again for research. Great Ormond Street, we have 90 minutes for an assessment appointment with those boys, and that's quite a long assessment itself, and we want to make sure what we are advising and recommending, it is actually suitable to what the child needs at that time, and that's why it's a long assessment. And it can be quite daunting, and sometimes it's hard to engage the child throughout the assessment, but we try to make as fun as possible to sort of get the whole family involved as well in assessment to get the right measure to then advise better. And what do we assess? There's a lot of things that we assess in physiotherapy. Sometimes that you might not understand why we're doing it, so that's why I am going through a little bit of each so you can have a better idea. So we do assess power, which, you know, muscle power, and there is a specific outcome measure that we use, which is called MRC, but it is the way we are grading the muscle and what kind of power they have through, because that will help us to see what's changed over time. And we do a lot of joint range sort of assessments, and we use a specific machine called the goniometer. Not many other places they do that, but we like to be a bit more specific when you're assessing. Then we check on the function, what the boys are up to at that time, and there is all these scales that we use, which many of you are probably aware. There's North Star, there's Brook, and the upper limb function, and it depends, and so on. And again, the assessment might change over time as well. We assess mobility, gait, fatigue. So I put these three together because mobility is not just the fact of walking. You know, you want to get yourself from A to B, and how are you going to get there? So that's something that I learned very young when I became a physiotherapist. One of my tutors said, like, okay, so they gave me this case scenario of a child in the middle of the room, all the toys were around it. So how are you going to get your child from the middle to the toys to play? So that's when I'm thinking about mobility, I think about the whole range, how I'm going to get a child to play around the things that's around it. So that's what we're thinking about as well, just not the fact of walking. The time tests and the 6-minute walk test, which is probably done more in research point of view, but that's something that you might see when you have a child with Duchenne muscular dystrophy. There's also other things that we assess, which are also very important, is spinal posture. We know that early on, when they're ambulant, the spine, it can be straight, but then we have to target and check all the joints that might be tight, because if you're managing those tightness early on, there is a less chance of the spinal deterioration later on in life. That's why we like to be assessing the spinal posture from the beginning. There is pain. That also, you know, some boys are pain, and you know, they still probably will have growth pain as well. It's something that we need to work on. And falls, because of the pattern of weakness, and then what we can do as physio to advise and to help, you know, to prevent falls as well. And home school, as I don't know if any of you here, or the child comes to Great Ormond Street Hospital, but we do not have an occupational therapist in our team, and then we also do this whole home school sort of assessment to help advise with our letter the local community to sort what's needed at the time. And we will have a look at their sitting and the way their wheelchair is working, or is it working for them or not? Is it supportive enough if and when they need it? And manual handling, of course, we have a parent, and the parent also has pain, and the parents also have other things to do. So we need to target them as well and give the proper advice on how to manage and manual handling those patients as well. And another thing that's very important, that you probably aware, most of them use a lot of splints and orthotics, and that's something that it might not fit, or it's not fitting properly, or it's not done correctly. So we will look at them in our assessments as well for to better advise. So, and then just as overall, after assessment, and what do we need to think about when we actually planning exercise program or advising properly, is contractures and stretches. So it's just the fact that contractures are to happen. How are you doing the stretches? We will ask the parents how they're doing, or how, or the caregiver, or how it's being done, and how often it's being done, so we can help and make then a bit more specific and tailored to this individual. Then we also think about weakness and exercises. We think about, again, mobility and function. Again, I keep emphasizing about the spinal posture, because weakness and tightness can lead to spinal deformities. And again, from a pain prevention point of view, if you have a tight joint, you probably will get pain. So we will also think about that. So this is kind of the assessment part of what I want to talk about. There's a lot to talk about, so I'm trying to concise as much as I can. And then what I will do now is talk a little bit more contractors. We talk a lot about contractors in physiotherapy, but not many people might really understand what's actually happening. And basically, they are tight muscles, and they can appear from at any age and any stage, and they are loss of muscle stretchiness. So I did this picture here, so I think you might have a better understanding. So we have this joint here is, I've just take a picture of that from there. It's just a graph of those pictures. So we have the humerus, which is this bone here, and the ulna, and then are the muscles here. We know that the Duchenne boys, they get some tightness of those muscles here. And then we have that muscle here, brachioradialis, which is a very, very, very strong muscle. So when you ask some of our boys to do this movement, what they tend to do, because of the weakness of that muscle here, they tend to rotate, we call it supination. So instead of doing here, they're gonna go do that. So the stronger muscles are taking over. And I'm saying that because when you grow, we all grow at some point, and then the bones always grow faster than your muscles, right? So, and that's why a child, even if you don't have Duchenne or any other neuromuscular condition, you might get some growth pain. And it basically means that when your bone grows, your muscle, they take a little longer to grow. They don't grow as fast as your bones. But a child who does not have any sort of neuromuscular condition, they will catch up. Those muscles will grow together with the bones. And sometimes by having an underlying condition, those muscles probably will not catch up. You probably will do stretches and stuff, and that's what we're working on. And sometimes they not grow as fast, and that's why you might end up with some tightness, because your muscles not growing as fast as your bone. So those are, when I'm talking about contractures, and that's what I'm really talking about. And then they can occur because there's weakness in the muscles, and then the muscle, as they weak, they will get tight as well. And so deformity caused by inability to achieve normal positions, in some muscle reliance on compensatory movements, which that I was explaining. So that muscle here is a bit stronger than that. So instead of doing this, they ended up doing that. That's just one example for you to have an idea what we're talking about. Again, just carrying on those. So contractures, they can appear at any age and stage. And we say, I mean, the hips joints don't just get tight at the loss of ambulation. Longer finger flexors, they can be tight as well, which is something that you have to know what you're looking for as well. There's no, if you have your arm straight and then you try to look at finger flexors, which this movement here. So if you do that, you might feel that you get the full range there, but once you actually get your wrist back, and then you try to extend those fingers, and then you feel like some of the boys might have this tightness of the fingers from an early age, and that's something we'll really be assessing from early on as well, because that will impact on functions, and just by holding things and brushing their teeth and things like this. So we want to target that at an early stage as well. Again, contractures, they can lead to pain because they're tight joints and they're not moving as much, and they can get pain, and they will, as you have pain, they will interfere with sleeping as well, and you know, the posture and the way you sleep, and they can cause pain just by sitting for a prolonged period of time, and then they can also be painful when moved. And the most important thing that I want to say will be on the next slide, which they don't get better by themselves. So there will be lots of work that we will have to do as physio, as parents or caregivers, and everyone that's involved in the childcare will need to be working on. So how would we manage those contractors? How we can make them, you know, have a joint that's functional for longer. So one of the things that we do is doing stretches. So the stretches sort of become sort of part the daily life. You're gonna try to make them part of daily life. Like for example, in the morning, like you brush your teeth, so we're gonna try to find a way that you can do a stretch while you brush your teeth. So if you're doing ankle stretches, so you're there on the wall, and then while you brush your teeth, I know it requires a lot of coordination. It might not work for everyone, but that's something that we try to incorporate. So that's why our assessments are very important to reflect the whole family, what the family is about, so we can tailor the stretch within the family as well. So what do we stretch? It's in Duchenne, I put the main ones, and we are trying to concentrate on those contractors that will cause loss of function or reduction of function. And for example, the TA, which is tibial, those muscles here and tendon here, and that makes the child do dorsiflex and plantarflex. So we target those ones. We target on finger flexors and elbow as well, because all movements that you need constant. And then we cause hips and ITBs as well, and the ones that affect mobility or ambulation, which you say you be repeated sort of muscles, because they are muscles that help with the general mobility ambulation. And we talk a lot about those ankle stretches, because I will explain a bit more sort of impacts they will have in function. And then we don't forget about supinators. So supinators is to do that sort of movement, and elbows, knees, and spine, and so on. So that's why the assessment will help us tailor what the child needs at that time. So just for you to have an idea, I'm just going to sit down so you can understand, and I just demonstrate. So for example, if you are to stand up from a chair, so what you do, you tend to bring your ankles back that way, so you need that range of movement here to then stand up, right? So if you do have that TA sort of tight, what's going to happen is, we know that the boys have weakness in the quads muscles, so it will be harder for them to get up from a chair or from the floor anyway, but with addition of TA tightness, that will become even harder. So what they tend to do is, so if that's tight, they ended up open their legs, and then the heel is not on the floor, so they try to get up from here with additional weakness here. It's really hard for them to get up. So they tend to sort of do something like that. They get that. So that's why it's very important that we keep stretching specifically the ankles to help and maintain this function. And things that we do not stretch, which is bendy joints. There's no point of stretching them. They're already bendy. Fixed joints. Again, it's fixed joints is joints that you try to move them. They're not going to move. They are tight, and they contracted, and you're just going to waste your time by doing it. There's things that you can still do about them if needed, but then we'll talk about later. And then painful joints, so there's no point. If it's too painful, you rather rest, have your time to, maybe massage or warm bath or things like this to help with the pain, but do not try to stretch painful joints because it's not nice. And the main one, which you always talk about, which creates a lot of controversies, is the hamstrings. So we believe that by stretching the hamstrings in an ambulant child with Duchenne muscular dystrophy, it's not beneficial. The reason being is, as I explained, they do get weakness here. So by having weakness on your quads, what's tends to happen is you sort of bend your knee. So by bend your knee, you automatically go on your toes to get your balance. And then, so what tends to happen, because this is weaker, they need another muscle to get them standing and keep up. So what happens is those hamstrings, they switch it on, and they switch on, and then once they switch on, they go in that posture. So that's kind of the posture that the Duchenne boys, they tend to walk. It's because of the weaknesses which you can't change, and they rely on that muscle. And we learned from early on in physiotherapy that shorter muscles are stronger muscles. So while I'm stretching something that is they are relying on to stand and keep up straight to make them longer and weaker. So we don't bother about hamstring. There might be a reason to stretch them, but not when they're walking. Later on, which Marion will probably talk about later in her talk, but as they walk, we just forget about the hamstring. Leave them there. They keep the boys up and walking, so that's how we believe. And just, so basically the methods that we have to maintain the muscle length and joint range. So I spoke about stretches, but there's other things that we do as well. And when you talk about stretching, we want something that's active. That's something that assisted stretch when active is not possible. Self-stretch, the more they can do for themselves, it's more beneficial. Again, the passive stretch, very rarely we recommend, but then we do stretching through position a lot. We recommend, which basically, if you're walking, if you're standing, if you're on your feet, you'll be stretching. So there's no, if you're doing movement, you'll be stretching your ankles and trying to keep yourself straight. So we keep advising on walking to stretch through positions. And splinting as well, which are your orthotics that we recommend. And there's something that, I don't know if anyone is aware, it's serial casting, which I will talk about as well. And of course, when we can't gain that, and there might be a reason, then surgery might be useful at some stage. How do we stretch? I mean, again, it's a common question from a lot of parents and caregivers. It is hard when you don't know, you don't have the qualification, but we try to really explain well what and how we're doing it. And we get parents that are unsure or caregivers in clinic, we'll get them to hold the joint and feel when we talk through it, and hopefully they understand. So you have to feel the muscle and to see if there's a kind of a give to that muscle. If the muscle is too stiff, as I said before, there might not be a reason for you to be stretching. So you've got to find that balance. And also, you have to go slow. If you go too fast, basically, in your body, we have this thing called a Golgi reflex. So basically, anything that if you put, it basically protects your muscles from overstretching. So if you try to really stretch hard, your body automatically gonna push away because that's a normal response from your body. So we want to get the person that's being stretched to help with the stretch. So when we ask them to do a ankle stretch, we ask them to do the movement and then we give the stretch. So what I'm going to demonstrate, if maybe Marion can come, I can actually demonstrate exactly how we would ask a parent to help their child with their stretch. Thank you. Yeah, that way is fine. Maybe that leg so they can see. So basically, no point of doing stretch with a bent knee because then you don't get a good stretch either. So straight knee, I'm just doing for comfort, but you can be lying or whatever. So relax. So what happened is, okay, I need to stretch his muscles. How I do? If I just do that, she automatically pointed out. So I don't want that. So the first thing I do, I said, can you bring your toes towards the nose? Yeah, perfect, because I was going to say that most boys, they sort of do that movement, invert, can you see that? So that's not helpful. So then what you then have to change the way you say by saying, can you bring your little toe up towards the nose? Then that's it, that's what we want. And once they do that, and then you get your up with your, it happens with your hands on the bottom of the foot, and then you ask, bring your toes up, bring your toes up, bring your toes up, and then escape because you're not getting a good hold. She's being mean. Bring your toes up, bring your toes up. But you got to ask them to do the movement. You can't just go and start and doing yourself. The more they do themselves, that's what we call the active assisted, and then it'll be more helpful and less painful, and it'll be easier stretch, and probably you have a better outcome as well. Yeah, that's just one stretch. I mean, there's other stretch that we also do with boys, but again, whatever stretch they need, it will be something that will, through our assessments, we'll then indicate what kind they need to be worked on that time. But this is one of the most important one that can most of the time be done in a way that's not effective as much as when you ask them to start the movement. So with those, as I said, it's an active assisted stretch, but we also sort of recommend a lot of self-stretch. Again, against the wall, and then with trying to stretch that movement here themselves, if they can, of course, and then neck stretches and some foot. Don't know if you recognize those Armarian kids when they were very young. But anyway, so those are self-stretch that we also recommend. And of course, if it's not possible, then we will assist them with their stretch. And other things that we do to help and support with contractures and manage the contractures are AFOs, which are ankle foot orthosis. Basically, they are splints. We recommend night splints or resting splints, or that's those ones. I mean, there's years of clinical experience and with Marion and things that she saw in the past. So we sort of, in a way, designed that with the orthotics team. It's trying to be something that's non-lined, so it's not very sweaty. And I don't know if you can see, but we call breathable holes in there, but I'm not sure how breathable they can be. But it's just to allow air in and not be very sweaty. And there is a strap there and there. And so that's actually the gold standard that we would advise. We've seen a lot of things because they come from us, and normally we don't provide them in our center unless there's a real need. But most of the time they do in a community, and then the kids come from different ranges of splints. This one, the idea of that one, there's a strap here, which apparently, so you put on, and then the parent or caregiver, the child, sort of stretch more. We do not want that. We want the child to sleep comfortably and in the 90 degrees position at the ankle, and that's what we want. We don't want it to be stretched overnight. I mean, who wants to be stretched overnight? I don't think it's comfortable. We want to maintain a 90 degrees position, and that's what we want. We don't want it to stretch any further than 90. Sometimes even the child comes with one of those, and we literally, because again, we can't change their local community or what they provide. We can give the advice. So what we're trying to do, I sort of try to get into 90 degrees and keep it that strap, so just do not move it. Just keep it that nice resting position, and you don't need to stretch anymore. And there is this one called CCD, control contractor device. It's something that when you're wearing, and I think they advise the child to sit still for 2 hours and then stretching. I mean, such a passive sort of stretch. And, you know, I rather have the child in standing, walking, getting their stretch by just being ambulant rather than sit still with that on. So, and it's going to be painful, and I think it's not very productive. So we tend to do the resting splints. And just to add, when you're sleeping, everyone's sleeping, if you sleep facing up, your foot automatically go into this position when you're in a resting position. And if you're on your side, same. And then if you're on your tummy, it's even more. So you walk away from that position. We do not want to encourage that because we know by fact that we'll get tight over time with the Duchenne muscle dystrophy patients. So by having this, your foot while you're sleeping is always going to be on that 90 degree. And that's what we want overnight. Yep. And so if it stretches or, orthotics, might not. So basically what I'm trying to say, you will be doing stretches and you'll be part of your life with the boys, but sometimes the condition will take over and then they will get tighter than you can manage conservatively or by doing stretches. We do something called serial casting in our hospital, and again, something that we have as a strict protocol, and this protocol is being designed over the years and with the clinical experience, and then we try to make as fun as possible. So this is all my artwork, this one is not, but I try my best. And the other thing we really encourage them is to stand on the cast as well. So it's basically, they come to a hospital maybe on a Tuesday, and then they stay with the cast for 2 weeks, and then we change cast. So if they come on a Tuesday, we then change on a Friday, and then Tuesday and Friday, so over 2 weeks. And basically, so we do that to gain range of movement in your ankle if their range is past plantar. If they're tight, that the ankles is like in that position, and then we try to use those casts to hope gain some range in there, and that's how we're trying to manage that. And sometimes they not work, so we might do for a few days. They come back to change, we haven't gained anything. Of course, we'll reflect on the way we've done, maybe we've done something differently, but then if you feel that it was not giving results on the first set of them, we're just not going to continue because it's counterproductive. So we tend to do as much fun as possible. If anyone is interested, want to know the protocol, the way we want to share with someone, just email myself and I'm more than happy to share with everyone. And just a bit of a background, that one was a quite interesting one and fun because the patient wanted a Disney. I said, Mickey Mouse? And he said, yeah, Mickey Mouse. And he said, and then he asked for a Minnie Mouse as well. I was like, why do you want a Mickey Mouse and a Minnie Mouse? I said, well, the Mickey Mouse is for me, the Minnie Mouse for my sister because she loves it. So it was quite a nice thing to do. And this boy was going to the premiere of the Minions movie, and then we made that, and he was very happy going to the movie them. So we try to make as fun and happy as much as we can. I kind of probably touched on it well already, but serial casting aims and benefits. So kind of increase ankle range, trying to improve the ability to climb stairs, walk, stand from chairs, as I explained. Sometimes we use to improve tolerance of night splints. So again, if your ankles are too tight and you're not being able to wear a splint for a while, we then do the serial casting to get them back on the night splints, which also called AFOs. Improve symmetry, because we worry a lot about symmetry with our boys, because if you have different length on your ankles, so you kind of have a different posture. By having different posture, you're going to cause problems elsewhere. So your hip's going to be not aligned, and then your back is also not aligned, and we want to prevent any asymmetry as possible. So then we want to have everything symmetrical. That's why we'll do that sometimes. Again, which I said, we still encourage them to walk in them. Might not be the easiest thing initially, but they normally get to walk in them as well. There are, of course, contraindication with most things. One of the main ones is no compliance and behavior issues, because there's sensory issues, or there's other aspects of autism or anything like this that can impact a child of having anything in their legs. Sometimes they don't even like the AFOs. So you got to take in consideration that's something that is going to be in them for 2 weeks. Sorry. And they might not be indicated. The other thing is scared of the plaster saw. So to remove that cast, we need to use that specific plaster saw machine, and it makes a lot of noise, and then they might think they might hurt. And I normally try to show in myself that it does not sort of cause damage to a skin or anything, but that's something that we need to show them and they can understand. And some of kids have some sort of allergies or reaction to plasters and things like this. So we also take in consideration. And of course, open wounds and infections. This needs to be healed before we put any plaster over it. Sorry. Yeah, so that's just the aim and benefits of the sclerocasting. So we spoke a little bit about contractors, how to manage, and now I'm going to get into a little bit of exercise in general. So physiotherapy, like if you work with adults, everyone, like most people prefer some sort of set exercise, which can be very boring. With kids, you might not get that. So we want anything that's fun. We want something that engages the whole family. We want something that is likely to be done and therefore will be more effective. So there's many ways we can do that. Through play. So a child that goes to a soft play, to a ball pit, pretend to be a superhero, mud club, and of course it depends on the age. You'll have different likes and dislikes, and the twister is one of the very good one because you sort of have to stretch a lot of your body by doing it. So like literally trying to be fun. And physiotherapy is not just pure exercise program, 5 sets of this and that. It's overall walking, getting from A to B, doing things with your family, and that's what we talk about in physiotherapy. And the other things is, which a lot of people might be happy, shows are exercises. So this is actually my son, but literally get them to do the washing. It might take longer though, but you can get them to get the things out of the washing machine or put in the washing machine. If you're going away, get a suitcase, you know. And if you have the time, this is all exercise that you can be built in a daily life. And also, just to help with that, I found a research by Harvard saying that children who are encouraged to do chores around the house are more likely to be happier adults, having more empathy toward others, and also more successful in their career. So there you go. So you can encourage them to do washing and anything, okay? Yes, so with exercise, again, anything that's symmetrical, and symmetrical, if you don't understand, is you have to use both sides of your body. Aerobic exercise, just moving, not boring exercise. Fun, and I keep repeating fun because they have to be fun to, so they're more likely to comply. And then, you know, exercise that we talk a lot about is swimming. Nothing wrong, swimming is, everyone should be swimming, and it's something that is great. It's reduce your body weight, so it's easier to walk, it's easier to do anything when you're immersed in the water. Horse riding, if it's possible, it's great because there's not much competition in the sense that everyone that does horse riding will be sitting. So, you know, everyone's doing the same, everyone's sitting, and again, you do a lot of movement in your arms, and they're a great exercise for them. Bicycle, tricycle, if not possible, one another, and boxing, again, arm work and standing, martial arts, basketball as well, and basically emphasizing anything that uses both sides of the body. Symmetry, we want symmetry. The not so good exercise. Well, if symmetrical ones are good, so asymmetrical not going to be good, of course, and concentric exercise in weights. So you probably read somewhere that it's not good for the boys to do sort of concentric exercise. Concentric, if you don't know, I just put 2 illustrative sort of image there. So concentric, it's basically when you shorten the muscle to contract. Eccentric, and when you elongate the muscles. So they say that's better for Duchenne muscle dystrophy to do eccentric contraction, which is this one. But again, you can read and trying to find really evidence about that. There's not much saying that you can't do it, but it's out there, and we try to avoid them. And exercise the wrong muscle group, of course. So if there is a specific thing that we need to take in consideration, we will then, of course, advise at the time. Again, just to add on the not so good exercise, so weights, rugby. I know it's very cultural in the UK, specifically I think rugby more than football, but rugby there's a high risk of injuries, and we don't want that, so we're trying to avoid. Gymnastics, again, they do a lot of things tiptoeing, we don't want to encourage that either. And trampolines, again, it's constant on the toes, and the fact that risk of injury. And once I was watching a lecture by a orthopedic consultant during the pandemic, actually, and he was doing sort of, he basically was counting the amount of trampoline injuries that he had through pandemic that came to see him, because he said during pandemic all the kids were home, and most family they have a trampoline, and then he said like it increased more than 60% case of injuries because of trampoline by them being at home. So we will avoid that, and we do not recommend. Scooters is basically the asymmetry thing we're talking about, just using one side of the body, and they will prefer one side of the body than another, so we don't want to encourage that. Running, I think running is more, again, it's kind of like they won't be able to keep up with the peers where they're running, so I think it's a bit frustration for them to do it, so we don't encourage as well. So those are the not so good exercise. And just to put out there, never stop moving. I mean, as much as you can. It doesn't matter if you're in a wheelchair or not in a wheelchair, there's always going to be a muscle that you'll be able to use. It could be your arms, your fingers, your head, whatever that movement you have, make sure you're using them, and we encourage them to be moved, right? Again, make it fun, make it, you also have to allow time to rest and recover. We all need it, but try to make it fun, and get the siblings together, or chase siblings, or go in a swimming pool, games in the pool, and things like this. They're all good exercise for those boys. So, moving on a little bit, I spoke about exercises, and there is a time that when the boys might start to struggle a little bit with the walking and mobility itself. And so there's things that we can still put in place to help them to feel safe, to maintain a prolonged walking, and help reduce falls, increase their confidence as well. And again, there's a lot of benefits of standing up for your overall well-being and digestion. There's something called, we call CAFOs, knee ankle foot orthosis. I don't know if you can see very well, but it's basically, it's sort of like the same material as the AFOs, but then it goes block the knee, and then there's something around the thighs as well. And at the back, there's a little lap thing that's for them to sort of rely to sit. But anyway, it's something that we can put on to help, because as I explained before, they get weakness in those muscles. So they will tend to do that way. And then those CAFOs will help block the knees from falling. And then they will be able to do a bit more walk for a bit longer. There is many reasons we use it, which those are the reasons that we might want them to use for. But however, there's also reasons that we're not going to use them. And again, it is their choice, and I mean, sometimes they don't want to do it, and they feel safer already sort of using more or relying more on the wheelchair. And we respect that. We talk with the family and see what's best for that specific family. And there's safety concern of, it could be even things like if they might use at school and there's people around and they can be knocked down and then still fall in a way. So those things that we will discuss in appointments. the compliance to rehab, because you put their arm, you need a little bit of rehab to get them really confident of using them. There's other things that impact is tightness of the joints, contractures. Again, if there's too much tightness, it might not be feasible for us to have that equipment. And again, not tolerated because of sensory or pain or whatever that could be. And if there's a child that might have poor skin or blisters, or the healing process is not working as well, so we have to consider that. We do have quite a few boys, not as so much these days, but that have and use it and enjoy it. So that's why there's a lot of talk before we put them into it. And there's before we get them custom made to the child, there's something that we used before, like as a trial, which is a gaiters. I didn't have a picture of it, unfortunately, but it's basically, it's kind of mimic that, but it's a big strap with metal bars, and we just strap around and then keep their knees straight, and we try that on first to see if they will like or enjoy that before even going into it. But that's an alternative to keep them on their feet for longer. Yeah, so what happened here as well, when I said about contractors, sometimes it's not feasible to have that because of TA that's really tight. So there might be on the Ambulant Duchenne, that a surgery of like a TA release with aim to use CAFOs. So once they go to hospital and they have, with the orthopedic team, they have that release, so then they get the foot and plantar. But it's very important that this child is thoroughly assessed and discussed before going for such a surgery, because the boys is on the verge of sort of still walking, need a bit of assistance, and might want the CAFOs. If they do the TA release, they're not going to be able to stand by themselves. Like, that's it. So that's why it's very important, if you're talking to your neuromuscular center, wherever your child is being seen, if there's a time that they need that where they're still ambulant, please discuss thoroughly. We are more than open that to come and talk to us about, and we can understand that child as well, because if you do that, it's very unlikely that they will be able to stand by themselves. The only way you'll be with those CAFOs. And then that's the consideration we have for this sort of surgery, which is the long steroid use, the level of mobility, what I'm saying, and general health, like cardiac, respiratory function, and things like that. The compliance behavior always will come up, and the understanding what is happening, what is needed, or what is being done, and of course the manual handling and equipment that needed. This is just a picture of the surgery. So it's not, I'm not going to be very technical, but it's basically, so this is your foot, this is your tendon here and the muscle, and then the orthopedic consultants do a little of a release in the tendon, so then you'll be able to get your foot a bit more a neutral position. And there is a very strict protocol that we do. Gosh, if the child comes to have the surgery with the aim to put them in CAFOs, which that explained, we will do a 3 days intensive rehab by the neuromuscular team, so then they can be discharged home and be safe using the CAFOs. It's something that we discuss with the family at the time and as needed, and then if they go through it. And one of the things I also want to talk briefly really is scoliosis, although not as much in the ambulant Duchenne, but everything I spoke about so far, symmetry and things like this, what we're trying to prevent later on is this, which is a very important thing to consider from an early age. We will check their backs every time they come to us, since they start seeing us, and it seems to affect 75 to 90% of the non-ambulant. But what I put there just to highlight the importance of having symmetrical joints, because if there's any asymmetry, it will impact everything else, and we don't want that. And we will persist, and we'll talk a lot about, stretches and keeping active and things like this, because we do not want that to happen. And we used to do in the past, use this, it's called TLSO, so thoracic lumbar spine support, with basically a spinal jacket, but then research has shown that does not help preventing the Duchenne muscular dystrophy patients to prevent any sort of scoliosis in future. So it's not used anymore than as a cross here. And then if they are to have that later on, I think probably Mario might talk a bit more, but then there's especially sitting and things like this that can be put in place to help. And then there might be a stage that they might come and have this the surgery, posterior spinal fusion. But again, it's a topic for another talk, but I just want to reiterate the importance of having symmetrical joints, which might not be possible, but we're working constantly on to get those joints symmetrical. It's sort of kind of the end of my talk, but the take-home message for me is every child and family are different. So, and that's why we persist on the 90 minutes assessment at Great Ormond Street, because you can't just ask a few questions and come with a tailored sort of recommendation or exercise program for a child. You need to understand the full background to be able to really properly give specialist advice. There are different needs and at different stages. Again, back to assessment, we need to do those so then we know exactly what we are advising. Moving exercise, so get these kids helping at home as well. So it is all exercise, and just by trying to bend and pick up from the floor and things like this is all exercise. Exercise has to be part of, stretches has to be part of the daily routine as well, because unfortunately it's something that you'll be needed for a long time. And that is all for me. Thank you very much for having me. If anyone has any question or anything, just please shout. There's quite a few.